Good afternoon, everyone. It's just gone 1 o'clock. I'm Melanie Carlton-Jones, as many of you will know. I'm part of the BSNR ESC, and welcome to Module 3, Oncology. We're in our 5th session, which is looking at imaging in CNS lymphoma. I'm really proud to be able to present to you Dr. Sam Mills, who is a consultant neuroradiologist at the Walton Centre in Liverpool, and she is the current RCR BSNR Du Boulay Professor. So we're really lucky to be able to have her presenting on this. She's taught lots of BSNR sessions before, and she's a fantastic teacher and she's got great cases. So without further ado, I'm going to give it over to Sam. We'll post some feedback links at the end. Please fill this out because this really helps us change how we alter and deliver future sessions. All right, thanks, Sam.
Thank you. Welcome, everyone. Today I'm talking about the imaging in primary CNS lymphoma. So I am based in Liverpool at the Walton Centre. I have a big research interest in a lot of neuro-oncology, predominantly lymphoma, meningioma, and to a lesser extent glioma these days. So we're going to talk about primary CNS lymphoma today. So what is that? Well, it's really when malignant cells in the lymph tissue occur in sort of the primary CNS, and that's in the brain or the spinal cord, the meninges, the CSF, and the orbits as well. The orbital lymphoma counts as primary CNS lymphoma. The talk's going to go through primary CNS lymphoma itself, talking about immunocompetent cases, immunosuppressed cases, and we'll talk a little bit about ocular lymphoma as well before we move on to secondary CNS lymphoma, and I'll just briefly cover that, and we'll go through some mimics as well. But the main focus of this session is going to be showing you lots of cases of primary CNS lymphoma, and to a lesser extent some of the mimics, and just a small bit on secondary CNS lymphoma. So lymphoma is not a particularly common tumour and would class as one of the rare diseases. It accounts for about 4% of brain or spinal cord tumours. About 5% of extranodal lymphoma is CNS lymphoma, but it's actually only less than 1% of all cases of non-Hodgkin's lymphoma. However, it is the third most common primary CNS tumour after GBM and after diffuse astrocytoma, so we see it quite often as clinical practicing neuroradiologists. It's subclassified based on the histological subtype of the lymph cells there, and the majority of cases in CNS lymphoma are diffuse large B-cell lymphoma. Chronic lymphocytic leukemia is also a variant of lymphoma, but that rarely affects the CNS. Only about 0.4% of cases affect the CNS, and it's usually as a form of secondary CNS lymphoma. So, as I've said, the majority of high-grade are diffuse large B-cell lymphomas, and that counts for about 90 to 95% of cases. Occasionally, you can get some rare T-cell lymphomas or low-grade B-cell lymphomas, and Burkitt lymphoma is also known to happen in the CNS, and it's more typical in the AIDS-related cases that you get the Burkitt's lymphoma. So epidemiologically speaking, there are about 0.43 cases per 100,000, and there's a slight male predominance. The incidence is probably increasing a little bit, and that's because we're biopsying more patients rather than the genuine incidence increasing. So before, things used to be passed off as high-grade primary parenchymal tumour, and they didn't really differentiate whether it was a glioma or it was a lymphoma because they didn't have a biopsy. They just got labelled as one thing, and some of those will have been lymphomas. The older a patient is, their risk of having lymphoma is increased, and immunosuppression is increased, with HIV and AIDS having a 3,600 times incident increase compared to the general population. But we have to remember as well that the medication for HIV and AIDS has substantially improved the clinical situation for these patients, and immunosuppressed lymphoma is becoming less common. So their presentation, of course, will depend on where the lesions are occurring. If they're in the brain, focal neurological deficits, neuropsychiatric presentations, seizures, and elevated ICP. And the majority of patients, as you'll know from doing routine on-call in general hospitals, often come via a stroke pathway, and that's like primary brain tumours. They've had a seizure, and it's mistaken that the Todd's palsy afterwards is mistaken to be a stroke. Spine patients often present with asymmetric sensory changes. They can have weakness in the extremities, and they may have bowel or urinary bladder dysfunction. In the peripheral nervous system, you can get radiculopathies that are very painful, or neuropathies. They can get cranial nerve palsies, and they can have painless polyneuropathies or peripheral mononeuropathies or multiplex. So ocular accounts for about 20 to 25% of primary CNS cases, and they usually have decreased visual acuity. They can have blurred vision. They often present with floaters, and about 80 to 90% of these patients will have contralateral parenchymal CNS disease, okay? It's very common to have bilateral orbital lymphoma and also concomitant parenchymal disease. So are there any guidelines to help us as radiologists for diagnosing primary CNS lymphoma? Well, the only NICE guidelines that are available are the ones on non-Hodgkin's lymphoma, which came out in July 2016. And when you search in there for CNS, all it tells us is about CNS prophylaxis in systemic lymphoma. There's no guidelines from NICE about how to diagnose or how to manage primary CNS lymphoma. Instead, the British Society of Haematologists, who actually treat the majority of the patients, majority of lymphoma patients, are managed by haematology rather than neuro-oncology, produced these guidelines back in November 2018. You'll be pleased to see it does have a neuroradiologist, Dorothy from Nottingham, Professor Auer is on there as a neuroradiologist, and it gives us some guidance on how to diagnose and manage patients with primary CNS lymphoma, predominantly focusing on large B-cell lymphoma, but that, as I've said, that accounts for the majority of cases, over 90% of cases. So there's a table from this paper that talks about essential things that are required. We need tissue diagnosis, and that can be either stereotactic or surgical biopsy. If they've got orbital lymphoma, you can do it from vitreous biopsy, and you can have a go at doing CSF if there are no other diagnostic materials. CSF yield is poor, and in all cases of primary CNS lymphoma, it's less than 25%. And the majority that we see as neuroradiologists, the parenchymal disease, it's far lower than that, and the yield is very low. So imaging-wise, it says we should do a gadolinium-enhanced MR of the brain and spine. It might be useful to do some cross-sectional imaging, PET, CT, and testicular ultrasound to check that it's not arisen, it's not a secondary CNS lymphoma that's arisen from elsewhere. So our guidance with regard to MR imaging is it should be contrast enhanced, we should have some diffusion sequences, and it should be reported by a neuroradiologist and cover the brain and the whole spine. It doesn't tell us what sequences or give us any protocols, but it says it should be reviewed by a neuroradiologist. So diagnosis of primary CNS lymphoma, tissue biopsy is the diagnostic gold standard in primary CNS lymphoma. And as I've said, lumbar puncture has a very low yield rate really in majority of cases. We need to bear in mind what's the prognosis of these patients. Without treatment, median survival is about 1.5 to 3.3 months. It improves with treatment to 10 to 20 months for median survival, and there are a variety of treatments, and the newer treatments do convey better survival, but they have their own problems, which I'll talk about later. So one of the key things we as radiologists have to do is ensure that people rapidly are aware that we're thinking that this patient might have primary CNS lymphoma. And we have altered our practice of these patients, our management of these patients at Walton, when we realised that delays to getting a diagnosis were resulting in potential poor outcome for these patients. So now if the neurosurgeon's been referred a case overnight, it looks like CNS lymphoma, they're advising to not give steroids, and they try and bring the patient in at the next available sitting for a biopsy straight away. We can't really afford to have a 2-week delay in getting a biopsy. Clearly it's slightly different with COVID, which adds an extra layer of complexity. So what imaging modalities have we got in our toolbox that we can use? Well, we've got CT, which of course is the imaging modality that the majority of patients will have first off because they present via A&E. But really we want to do MR imaging of these patients. We've got the conventional sequences, T1, T2, FLAIR, and we've got diffusion weighted imaging, which I would class as a conventional sequence. And then we've got the more advanced sequences such as spectroscopy and perfusion imaging. And then there's PET as well. We don't really do much PET at all in Liverpool. It has to go to a different centre. So we tend to focus predominantly on MR, and that's what I will be talking about mainly. So the majority of cases of primary CNS lymphoma are parenchymal, and only about 1 to 7% have disseminated meningeal or intraventricular disease. So when you see that, it's more likely to be a secondary CNS lymphoma. So I've got a poll for us here. I'm going to ask the audience in how accurate are we in diagnosing CNS lymphoma on MR as neuroradiologists? And I'd be really interested to know what people's thoughts are on this. And this is just based on reading the reports, okay? General MR, so if we can have a think about that and submit that poll. And we'll just wait a few minutes or a few seconds to see what people are thinking. So in clinical practice, the neurologist will tell you that good clinical diagnostic accuracy should be about 95%. So the majority of our audience say that our diagnostic accuracy is somewhere between 40 to 80%. Well, that 50% of the audience have thought that. 26% of the audience have gone for the 80 to 95% range, and only 2% of you thought we were really good and greater than 95%. Okay, so let's move on. So radiological accuracy, there aren't actually many studies that assess this properly, and the only one that's really in the literature and is widely quoted is from 2010, so it's quite dated, and it was only in 26 patients. So there is a real cry out for much larger scale studies where we just look at the radiology report and compare it to outcome, and the actual histological diagnosis, and these pragmatic studies to get real life analysis of how accurate we are. This study showed it was 39%, so right in the bottom range of our diagnostic accuracy. Well, we had a look locally. This is a while ago, and this was published at ASNR in 2018 as part of another study to see what our accuracy was. And we looked from 2007 to 2016. We just went through a literature search on all the case radiology reports where they mentioned lymphoma, and we identified 503 radiology reports for 399 patients. We then went through the imaging and basically excluded meningeal disease and excluded people who were known to have systemic lymphoma. And if there wasn't any enhancement, we tended to exclude that. So we found 136 parenchymal lesions that enhanced and could be compatible with lymphoma, and that was raised on the report. And then of those, a proportion were biopsied, 88 were biopsied. And this is the results from the biopsy. We couldn't find the results for 14 of them. 10 of them were inconclusive. One of them came back as normal, which I suspect is probably that they've just missed the actual lesion. So when we exclude those ones, we get a 63% hit rate total with a 59% accuracy. So we're better than the literature, which is good and reassuring, and it was done a while after that first survey. But what can we do to improve radiological accuracy? What features can we look at on the conventional sequences, on the advanced sequences, and on the multimodality images? And radiomics I'm not really going to cover, but there are a couple of papers out there. So conventional sequences, there's a few papers in the literature that talk about the conventional sequences and what imaging features we should look for. But if you look, there's a nice pictorial review from Tom Booth, which was in 2011, but it's just that, it's a pictorial review. It doesn't give us any evidence other than from the literature that's available. There's this study from 2019, and they've only got 27 cases in there. And there's a much larger study here from 2019 with 118 cases. But there are a lot more lymphoma cases out there in the literature. It's just people looking in one centre over a long period of time. So there is potential to improve this. What does it tell us? It tells us that the majority of the lesions occur in the cerebral hemispheres, with a vast proportion occurring in the basal ganglia region and the thalamus and the corpus callosum. Ventricle lesions are a little bit more unusual, and cerebellar lesions account for about 5%. About just under half of them have multiple lesions, and if you're immunosuppressed, you're much more likely to have multiple lesions. And this all comes from this larger paper where they had 100 and odd cases. So here we go. Start with some images now. So this is a very typical case of primary CNS lymphoma. We've got a CT scan here, we've got an axial flare, and then we've got the post-contrast axial and coronal T1 weighted sequences. If we look on the CT, the lesion is hyperattenuating. This is a non-contrast CT and it's hyperattenuating. And that's because lymphoma is very cellular. Okay, so as soon as it's cellular, you're going to push up the density. The T2 It's isointense really to the cortex. Sometimes it can be a little bit lower, sometimes it can be a bit higher. It's a bit variable. So T2 signal hyperintensity is thereabouts, roundabout cortical signal intensity. The enhancement pattern is very homogeneous. It's almost like someone has taken the scan and taken the white paintbrush and painted it white. It is just smooth and homogeneous and even enhancement throughout it. This is another example looking at the CT. We see the lesion is hyper-attenuating and we can give contrast on CT and it enhances homogeneity. Now, in my routine clinical practice, I don't normally give contrast on the CT, and that's because what you really want to do for these patients is you want to do an MR scan. So there's no point doing another examination and giving them another dose of irradiation. You should just move on from that CT to an MR scan. That's going to give you better lesion characterization and you'll be able to determine what type of tumour it is, be it a lymphoma or a glioma, more easily on an MR than you will on a CT. So it's a waste of contrast and it's a waste of radiation. So here we have some T2 weighted sequences and a post-contrast T1. This patient, their lesion's a little bit lower signal on the T2 compared to the cortical grey matter, and it's more in keeping with the white matter. And there's quite extensive perilesional vasogenic edema surrounding it. Again, the enhancement pattern is very homogeneous. It's like someone has painted it. This is the same lesion, looking at it on the flare now. So it's not very bright on the flare. There is some, it's more isointense to the cortex, but it's not cystic or very fluid signal in there at all. When we give gadolinium, we can see that the enhancement pattern again is homogeneous. It's very difficult to appreciate it on non-contrast CT. We've got a parenchymal lesion here, and then we can see that it actually sits at the brain CSF interface, and it's very common for these lesions of primary CNS lymphoma to occur at the brain CSF interface more so than in the deep tissue. Diffusion weighted imaging is extremely useful in assessing lymphoma, primary CNS lymphoma, and that's because, again, because of the cellularity of these tumours. Because the cells are so densely packed together, it restricts the movement of water, and the extracellular, vascular water movement is not able to move as much, and it gives us low signal on the ADC. We see it here on the T2, similar to the cortex. There is restricted diffusion. It's bright on the isotropic trace, and then it's very dark on the ADC map. There's a little bit of shine through artifact at some other places as well, but it enhances again homogeneously. Callosal locations of lymphoma. Again, we've got a solid lesion here. We've got the CT, it's hyperattenuating. On the flare, it's a little bit high signal, but on the T2, it's isointense to the cortex. There's a little bit of perilesional signal change around it. On the diffusion weighted imaging, it is restricting a little bit. There's, the ADC is slightly low, and we can see we've got a parenchymal lesion here, and there's also some periventricular ependymal lesions too. So what if we measure the actual ADC? Does that really help us? Here's a good example, restricting lesion. The ADC is very low, ADC in the range of 600. Well, the literature tells us when they've looked at this that yes, it's quite good for differentiating between primary CNS lymphoma and GBM. But if we look at them, I'll see the blue here on this paper is the lymphoma and the red is the GBM. The lymphoma typically has lower values of GBM, whether you do the mean, the minimum, or the maximum ADC measure for all things, and that's when you choose selective ones or just do unselective, sampling the whole lesion. And this is the same on this paper, where they've looked at the ADC values, the minimum and the medium, and on this paper too. The ADC is typically lower in primary CNS lymphoma than in GBM, but if you look at them, there is a lot of overlap. So it's not really going to separate. It will just aid us and point us in the right direction of trying to decide whether it's a GBM or whether it's a lymphoma, but it's not a clear-cut, distinctive way of separating the tumours. So what advanced techniques have we got? Well, there's a nice review article that came out last year by the Birmingham group on multiparametric MR and a practical approach, the pictorial review again. It's quite nice. It's just got a few cases in there, but it gives you an idea of what things can look like. There are some studies where they've looked at the advanced imaging sequences. And there's this one again, which looks at just the conventional, but also looks at perfusion and spectroscopy as well as PET-CT. And then there's this study, which looks at dynamic susceptibility contrast and ADC measures differentiating primary CNS lymphoma from GBM. This is a very historic image from when I did my PhD. So we've got DSC perfusion imaging, and we've also got DCE permeability imaging. We've got a lesion on the top that shows peripheral enhancement with central necrosis, which is a GBM. And if we look at the blood volume map, the periphery of this has an elevated blood volume, and it's also got high leakage with it and permeability. The lymphoma demonstrates far more homogeneous enhancement and is well defined. It does not have an elevated blood volume because they are not vascular tumours, but it does have elevated permeability because the contrast is leaking out. So what does the literature show us? Again, similar to ADC, it shows us that blood volume is typically lower in the primary CNS lymphoma group, okay, compared to the GBM group. And this is the same on all papers. Okay, but again, there is overlap. So it's not going to give us a clear-cut method of distinguishing from a GBM or a lymphoma. If we look at spectroscopy, how does this help us? Well, here's an example of a lymphoma on spectroscopy from this pictorial review. We see the lesion here is callosal. It's not really got any necrosis in it. The ADC is quite low. It's measuring less than 600. It's not really got elevated blood volume in it. There's a little bit around the edge, but that's probably where the vessels are displaced. We see that it's got a reduction in NAA, and there is some increase in choline, but there's also a lipid peak. If you have a non-necrotic tumour that's got a lipid peak, you should think about lymphoma. So it's one of the ways that can help direct us. But again, it's not always clear-cut. This is spectroscopy of a mimic. This is tumour factor demyelination. You'll see that again, the NAA is down and the choline's up. There is some lipid and lactate, but the peak's not as high as it was in the other lesion. If we look at the other sequences, there's a leading edge, peripheral edge of enhancement, and it's just the leading edge that restricts. And this is tumour factor demyelination. I'll talk a lot more about demyelination as we go on through this talk. So this paper looks at the added value of spectroscopy. How about we take all the different modalities we've got and combine them together to try and improve our diagnosis? Well, it does have added value. So we see here cerebral blood volume. The primary CNS lymphomas have got low blood volume compared to the GBMs and the metastases. But there is some overlap. When we start adding in the other things, they give us other ways of distinguishing between lymphoma and GBM, particularly choline NAA ratios, and particularly that the lipid ratios as well are quite important. And as I've already said, we don't particularly do PET imaging in Liverpool just because it's not readily accessible for us in our tertiary referral centre. They have to go to the Royal Liverpool Hospital, and there's just not much liaison between us and them. So most of our work for the lymphoma patients and all the glioma patients is predominantly on advanced MR metrics, but it is FDG PET active, and it will light up like a light bulb because it's highly metabolic. Okay, so it can help identify it. It's used more often for the secondary lymphomas to see if there's spread there. So as I've said, the guidelines, the British Society of Haematology guidelines, say that tissue biopsy is the diagnostic gold standard in primary CNS lymphoma. So what do we mean by that? A gold standard test is the diagnostic test or the benchmark that is the best available test under reasonable conditions. The really important thing to note is it doesn't mean it's 100% accurate. Sometimes we get these patients who have partial enhancement. So we've got a lesion here of the genu. It's quite bright on the T2. It shows some restriction in it. When we've given contrast, there's just peripheral enhancement. And there are a number of reasons why we might not get that nice, homogeneous, well-defined, smooth enhancement that we all associate with lymphoma. And that one of those is cardiac output and timing. So a lot of these patients are very elderly. And one of the most common mistakes with all post-contrast imaging in neuroradiology is the radiographers give the injection of contrast and then immediately do the post-contrast T1 weighted sequence. If you look at the BSNR guidelines for glioma imaging, you'll find that there's a spacer sequence, there's a flare sequence in there that is devised to allow a set time and allow accumulation of contrast, so you get maximum enhancement. The older a patient is, the more likely they've got reduced cardiac output, and there may be a delay to reaching maximum contrast enhancement. Steroids are a massive confounder, and historically the gut reaction when people saw a enhancing brain tumour is to automatically give them steroids, because that will reduce the mass effect, reduce the edema, and symptomatically improve the patient. The trouble with steroids is that, of course, it has an effect on the lymphoma and can reduce its amount of enhancement. It can reduce the amount of edema, which is good for the patient, but it's not so good for the biopsy. And we'll explain that as well. If a patient's immunosuppressed, so they're either a post-transplant patient and on immunosuppressive therapy, or they're HIV and AIDS, that can also cause this partial enhancement and central necrosis. And of course, the other things we make mistakes with are mimics such as GBM, or in the context of immunosuppressed patients in HIV and AIDS, toxoplasmosis can be mistaken. So steroids. Corticosteroids induce apoptosis, so you've got fewer viable tumour cells, which means when they go in and do the biopsy, they've got a lower chance of getting a good diagnostic yield. It may, at the biopsy, just result in showing a mixed infiltrate, so you get some macrophages and lymphocytes and plasma cells and necrosis, and you won't get your large collection of B cells that you need for your diagnosis of primary B cell lymphoma. You can also induce an inflammatory reaction and a peripheral demyelination by giving steroids, and even without steroids, that reaction can be induced by the lymphoma itself. So this is an example of a patient who, this is their first scan, they'd already started steroids the moment that they'd had their CT. And this was the imaging. There was a delay to getting them over for a biopsy, and by the time they came for their scan for biopsy, we can now see that there's been substantial reduction in the extent of the lesion. So it's less likely that the surgeon is going to get an accurate diagnostic specimen. Okay, so we've tried to train on neurosurgery registrars. It's always difficult when there's a change of a bunch of new trainees come through, but we try to teach them that don't give steroids if there is a possibility that this could be lymphoma. The steroids can wait for 24 hours until it's been reviewed by a neuroradiologist if needs be. But if you're thinking the patient might have lymphoma, you need to withhold the steroids. And this moves us on to the second part of the audit we did. So of those 88 patients that had a biopsy, 11 of them went on to have a repeat biopsy, because the initial biopsy was either inflammatory or inconclusive. One of them actually came back as an astrocytoma. And you'll see that with repeat biopsy, we've now got another 6 cases of primary CNS lymphoma. So our radiological accuracy has gone from 59% to 61%, because the first histology was not correct. So the gold standard is not 100% accurate, and we have to remember that. We also had a look at that cohort about the delay. If you had to do a second biopsy, it introduced a delay. And if you introduced a delay, patients tended to do a little bit worse. Because it's a disease that carries such high mortality without treatment, you want to get that diagnosis really quickly. And if you look at this, the patients who don't get a biopsy or don't get a conclusive biopsy, they're never going to get treatment. So they're going to die really rapidly. So it's these patients we need to think about. We need to improve how we can diagnose these patients, both radiologically and even histologically. So this was our initial X-ray, and then I'm going to just highlight this one case here, this demyelination case, because when they came back for their third biopsy, that's when the diagnosis of lymphoma was made. And I'm now going to introduce you to a concept called sentinel lesions with regard to primary CNS lymphoma. So there are a series of case reports out there which describe an inflammatory demyelination as a precursor of primary CNS lymphoma. And the initial biopsy of these lesions will reveal demyelination. This can occur either spontaneously or steroid related, and you get a remission. The patients then have an extended period of stability until eventually they get a re-emergence of their symptoms, and ultimately they get diagnosed with primary CNS lymphoma. So I'm going to acknowledge my intercalating MSc student here, Max Norrington, because he did a lot of work on these two cases that I'm going to present. And also, this was first reported back in 1996 as a concept. So this is our first case. This was a 37-year-old female who presented with a 4-month history of headaches, nausea and vomiting. So she had an MR scan which revealed this mass lesion here in the right frontal lobe and extending into the basal ganglia. There's enhancement which is relatively homogeneous, although possibly leading edge, but you see it all corresponds to the T2 abnormality. The radiologist said, oh, it's probably likely to be primary CNS lymphoma. Routine blood and CSF at the time was normal. She received some corticosteroids because this was back in 2012 and went on to have a biopsy. So the biopsy revealed patchy demyelination with axonal sparing and an inflammatory infiltrate of perivascular CD3 positive cells and some macrophages and some scattered CD20 positive B cells. There was no demonstration of any clonal populations, so malignancy was considered to be less likely, and the patient, being only 37, was diagnosed with tumor factor demyelination. She continued on dexamethasone for a period of time, and the lesion regressed, and she improved. The patient remained asymptomatic and continued to have follow-up surveillance imaging for quite some time. She came back in March 2018. Unbeknownst to us at the time, she was in her first trimester of her 3rd pregnancy. And this time there's some new enhancement, a little bit of periventricular enhancement adjacent to the frontal horn of the left lateral ventricle. She was under the neurologist. She was quite well, completely asymptomatic. She had a lumbar puncture at that time, which showed normal oligoclonal bands, so it wasn't an oligoclonal band positive. It was negative for aquaporin 4 and anti-MOG, so this isn't looking like an inflammatory based on the CSF, but the neurologist decided that she still had a tumor factor demyelination and continued to treat her as such. In her 3rd trimester, she had another scan without contrast this time because of the pregnancy, which showed she was relatively stable and she was quite well. She gave birth in November of 2018, and then 3 weeks later developed poor coordination and weakness, and this was followed by a seizure. Imaging then revealed recurrence of the enhancing lesions, again periventricular, but very homogeneous and solid enhancement. At that time, the neurologist decided that it was still recurrence of the tumor factor demyelination. She had a CSF at the time, which was 1.6 grams of protein, but she was treated with methylpred and 5 cycles of plasma exchange. She didn't get any better. She went into status and required an ICU admission, and she was repeat imaged. And this is what the scan showed that time. Diffuse, florid, homogeneous, very intense enhancement with multiple lesions. She was very unwell. We also did some DCE perfusion imaging on that time. There was no elevation in blood volume, but the permeability was very high. And we persuaded the neurologist that this wasn't tumor factor demyelination and she needed a biopsy. She went on to have a biopsy at that time, and it revealed this time B cells were expressed in a high proliferation index with an elevated Ki67, unequivocally signifying that she had DLBL, which is primary CNS lymphoma B cell type. She's gone on to have chemotherapy, commenced in March 2019, and she, to this day now, she remains in remission and is well. Okay, so she had a very prolonged period of good health, and it relapsed and went into remission from 2012 all the way through to 2018, and her diagnosis wasn't made until 2019. We have another case as well at our centre, which is an elderly gentleman, a 72-year-old man, who presented with 4 weeks history of confusion, urinary incontinence and expressive dysphagia. He has a family history of multiple sclerosis and was a heavy smoker, and this is his first scan, which revealed this very homogeneously enhancing lesion in his left frontal lobe. He'd also received some steroids for symptomatic control, had a biopsy, and the biopsy again revealed sort of a patchy demyelination with some axonal loss. There were a few B cells in there, but it was a perivascular infiltrate, and they decided it was tumor factor demyelination. He was treated with steroids, he improved, so he had clinical radiological improvement, went to remission until a routine follow-up scan. 4 months later, he represented with some more symptoms. There was a little bit of enhancement in the lesion that time. He was treated again as a demyelination and relapse, and he remained well until 19 months later when his behaviour deteriorated and his memory declined. He was scanned again, and now we had these diffuse, big, homogeneously enhancing lesions, rebiopsied, but required steroids for symptom control prior to biopsy. But this time we had definite histological confirmation of primary CNS lymphoma. He had 4 cycles of chemotherapy and had a partial response, but unfortunately relapsed and died 5 months after the second biopsy. But this patient, we've got another 3-year period of from first presentation to absolute diagnosis with remission in between, and the biopsy originally showed demyelination. So these in keeping with the sentinel lesion. Both of our cases received steroids prior to biopsy, and we've tried to sort of stop that practice now. Of note, the radiology reports throughout the history of both patients, the neuroradiologists consistently said they were concerned about primary CNS lymphoma rather than demyelination. So sometimes the radiologist knows more than the pathologist. The initial biopsy in both cases demonstrated this patchy or incomplete demyelination. And there are a few papers coming out now from the histology side of things, from the pathology world, saying if the demyelination is incomplete or patchy, you should think whether or not this patient has got primary CNS lymphoma rather than a tumour-factive demyelination, because tumour-factive demyelination should be a complete demyelinating pattern. So it's recognising different histological patterns of disease. So histology, we have to be aware of the limitations of histology. There are problems with specimen quality because, of course, your biopsy, your histopathologist can only look at the sample they've been given. If the surgeon misses, they're going to get normal brain. If they've biopsied the edge of the lesion, it might be confounding, and it might be an inflammatory reaction to the CNS lymphoma rather than the lymphoma itself. If the patient has received steroids, of course, it may alter the histology of it, or it may have disappeared, making it more challenging for the surgeon to target. I've discussed the concept of sentinel lesions as well. And this is the big problem we have with primary CNS lymphoma, is in order to get tissue biopsy, the patient might have a lesion in a location that is not suitable for surgical targeting, or because it's an elderly patient, they may have comorbidity. And this causes problems with diagnosis. And it's something these patients are always missed out of. If you've not got a diagnosis, it's often in the literature, they'll say you've not got lymphoma, but of course they've just got a lymphoma without a diagnosis. So they're kind of a forgotten cohort of patients. So let's talk about some of the other patterns of primary CNS lymphoma that we need to recognise. We've said that 1 to 7% of them will have leptomeningeal or ventricular disease, and this is very typical of ependymal lymphoma, and we've got some enhancement that is lining the ventricles there. There's a little bit of mass effect and perilesional signal change around. You can see on the T2 weighted imaging, but it's very difficult to appreciate a solid tumour on that, and it's really just the ependymal enhancement. It can involve the cranial nerves, and this has been reformatted to show the enhancement of the ocular motor nerves bilaterally. This patient happened to have secondary CNS lymphoma. This is a primary CNS lymphoma, but it is involving the cranial nerves, and you can see we've got trigeminal nerve involvement, as well as vestibulocochlear and facial nerve involvement, and then there's leptomeningeal spread coating over the superior aspect of the cerebellum with some cerebellar parenchymal involvement as well. Leptomeningeal involvement, we can see this in the spine more often than in the brain itself, and it's coating here the whole of the spinal cord. All the nerve roots of the cauda equina are coated. We see it on the axials, just encasing the spinal cord. And it can involve the bone as well as the peripheral nerves and the sacral plexus, and this is a sacral plexus lymphoma with adjacent bone involvement, and we can see the nerves enhancing, extending. We can see the whole of the bone marrow is abnormal in that S1 vertebral body, and these are our fat suppressed post-contrast sequences, and we see both sacral nerves and the sacral plexus lighting up quite avidly with contrast enhancement. We've got this one here, which is a durally based lesion, which is extended through the skull vault. So there's been intraosseous, intradiploic spread, and there's now extracranial disease. And we can see this moth-eaten appearance to the bone on the CT and a very large lump outside. But we can see it's causing mass effect in the adjacent brain parenchyma. And then, of course, we have the rarities. We have a pituitary adenoma here, which we thought was going to be just a normal pituitary adenoma. So much to our surprise when the histology came back that it was pituitary adenoma with collision with primary CNS lymphoma cells within it as well. But pituitary lesions are well known in the literature. There are a number of case reports that talk about pituitary lesions and metastatic disease from other causes, cerebral metastases, and it's to do with the vascularity of them and the lack of a blood-brain barrier intercept. So moving on from the other types of primary CNS lymphoma, we've got primary interocular lymphoma, which is a subset of primary CNS lymphomas, and it's either identified in the retina, in the vitreous, or the optic nerve head. 80% of these cases are bilateral, and 80 to 90% also have coincidental CNS parenchymal involvement. LP is a little bit more sensitive on these ones, with a 25% hit rate. And you should think about it if the patient's got chronic uveitis, which is unresponsive to steroids, if they've got blurred vision or floaters, and they're a little bit older, you should think about it as well. So fundoscopy, I realise this is something we don't do as radiologists, but this is what it looks like. They have these cream or yellow subretinal infiltrates. So the ophthalmologist usually diagnose it on fundoscopy and then do a vitreal biopsy, or and they don't often do MR imaging. MR imaging has a very limited role, and it's really to assess parenchymal disease. And here is an example. They're not fat suppressed sequences, but there is intraorbital lymphoma, and we can see that there's some parenchymal disease here, and this patient was diagnosed on a vitreal specimen. This is another example of ocular lymphoma. These are fat suppressed post-contrast T1 weighted sequences, and we can see there is extensive enhancement within the orbits, and this same patient has leptomeningeal disease, which is coating the cervical spine at the craniocervical junction. So immunosuppressed CNS lymphoma, of course, it's most well recognised in HIV and AIDS, but immunosuppressive agents such as azathioprine, methotrexate and mycophenolate are also recognised causes. Post-transplant lymphoproliferative disorder should be classed as an immunosuppressed CNS lymphoma, and angiocentric lymphoma is also a variant of immunosuppressed disease. All of these are associated with prior Epstein-Barr infection. So they have a very typical appearance of immunosuppressed primary CNS lymphoma. It's very heterogeneous, peripheral enhancement, central necrosis. It's often multifocal, much more often multifocal than in immunocompetent lymphoma, and there's often much more extensive vasogenic edema. There's a couple of papers from the literature that are quite historic now. There's an old pictorial review from ClinRad from 2006, which has got some quite nice images. And there's a more recent one from Neuroradiology from 2014. And then there's this one from the Lancet from 2017, which shows very much a hyperattenuating mass lesion involving the corpus callosum in the splenium. It's hyperattenuating because it's highly cellular, because it's a CNS lymphoma. This patient hasn't got any necrosis. It does demonstrate that normal homogeneous enhancement pattern, but in the context of knowing that the patient's got AIDS, it's an AIDS-related primary CNS lymphoma. So post-transplant lymphoproliferative disorder as a whole develops in less than 2% of patients, and it's a spectrum of disease in the whole body. So it ranges from sort of lymphoid hyperplasia systemically all the way through to lymphoma. Primary CNS post-transplant lymphoproliferative disorder is pretty much associated with a lymphoma type of picture. It's more commonly seen when patients have received azathioprine lymphosuppression, and it's been decreased. We see it less often with the newer agents such as cyclosporine. And again, as I've said before, it's Epstein-Barr positive. This is quite a nice paper from 2019, which just gives you a pictorial view of primary post-transplant lymphoproliferative disorder of the central nervous system, very much ring enhancing lesions, central non-enhancement, occasionally they have solid enhancement, and they look like an immunosuppressed lymphoma. Angiocentric lymphoma is also known as lymphomatoid granulomatosis. It's associated with Epstein-Barr virus. 20% of these patients will have a CNS involvement. And this is demonstrated with punctate or linear T2 signal hyperintensities within the perivascular spaces. And it may or may not have leptomeningeal enhancement. And this is one of our cases. We can see it's sort of white matter, T2 signal hyperintensity, the little punctate areas that become more confluent. It does demonstrate a little bit of restricted diffusion, but there's also some shine through. And then on the post-contrast sequence, we've got multiple little nodules, tiny punctate bits, and then a coronal reformat shows you there's a very striking linear component as well. And this is an angiocentric lymphoma. So secondary CNS lymphoma obviously originates from outside the CNS. It's typically a non-Hodgkin's variant. It can occur as an isolated recurrence or concomitant as part of the systemic presentation. Unlike primary CNS lymphoma, 2/3 of secondary CNS lymphoma cases are leptomeningeal, and only about 1/3 of them are parenchymal. So this is an example of somebody who we knew had systemic pelvic lymphoma, and then presented with some seizures, and they've got a large mass, and this is secondary CNS lymphoma. Right at the beginning, I talked briefly about chronic lymphocytic leukemia. So this is a variant of secondary CNS lymphoma. It is extremely unusual to get CNS involvement from CLL, unless it's about 0.4% of cases. And this is just an example here. It's very much leptomeningeal disease. And the one thing I would say to you, unless you give contrast, it can be quite challenging to see. And if you've got to rely on diffusion weighted imaging shows there is some restricted diffusion, very avid restricted diffusion of this lesion. There is failure to suppress properly on FLAIR imaging, but it's almost impossible to see on just T2 and non-contrast T1 weighted sequences. I've also got a side of primary lymphoma of the bone in this series because, of course, it can cause cord compression, and that's how we see it as neuroradiologists. And this is a primary bone disease that has extended to cause compression. Mimics, this is the other reason we get it wrong. There are diseases, predominantly gliomas, when we looked at it, that we mistake for lymphoma, or more often than not, we have a differential diagnosis that says this might be an intermediate grade lymphoma or possibly a primary CNS lymphoma. And here is an example of a lesion. It's showing restricted diffusion. It's very cortically based. It's at the brain CSF interface. There is some enhancement following contrast administration, but it's not particularly homogeneous. And this turned out to be an anaplastic astrocytoma. This is another case, very similar, more homogeneous enhancement this time, but it's very ill-defined and diffuse, and the perilesional signal change has a bit of mass effect with it, and I would say it's more likely to be tumour, and again, it's an anaplastic astrocytoma. A third case, we can see here we've got ill-defined cortical lesion with ill-defined white matter signal hyperintensity. There is some restriction, but it's not that low. The post-contrast, although it's homogeneous and well painted on, it's a bit remote from where the actual area of restriction is, and this was an anaplastic astrocytoma. Occasionally we get some unusual diseases. So this lesion doesn't enhance. We see it clearly on the T2 and the FLAIR. There's peripheral rim of restricted diffusion, but the blood volume here shows that it's a very vascular tumour. And the reason it might not have enhanced on here is that this patient was elderly and in their 80s, and we should probably have done a delayed post-contrast, a little bit further delayed down the line. This is another case, very homogeneous. It shows some restriction, homogeneous enhancement, restricted diffusion. A little bit higher up, we've got a tiny bit where it's not enhancing in it, and we see that there's not restricted diffusion in that bit, it's more facilitated. We do a fusion scan, and this is actually a GBM rather than a primary CNS lymphoma. GBM, if the patients receive steroids, it can be difficult to decide whether something is a closal GBM or a primary CNS lymphoma. I would have gone for a GBM on this, but of course you can't exclude a partially treated lymphoma. Multifocal GBM, we've got multiple lesions, peripheral enhancement, restricted diffusion. They are restricting quite avidly, so it's a very cellular lesion, and this turned out to be a GBM. Germinoma can give you this ventricular enhancement, and again, it can be mistaken for that ependymal variant of CNS lymphoma. Neurosarcoid is another great mimicker of many diseases, and here we've got an enhancing lesion. It shows, it's very difficult to see on the T1, but you've got T2 signal abnormality there. They happen to have a CT, which shows that they've got some lymphadenopathy. It's a young patient, and this turned out to be neurosarcoid. Another case of neurosarcoid, we've got ependymal enhancement. We knew this patient had sarcoid, so lymphoma shouldn't sit in the differential. But it shows you how it can mimic some of the meningeal and leptomeningeal disease. So multiple sclerosis, which is actually multiple sclerosis, this patient's got a periventricular lesion, which demonstrates homogeneous enhancement. This is in 2012. Biopsied, came back as complete focal demyelination. 8 years down the line, there's still some signal change there. We've now got some new juxtacortical lesions, and we can also see we've now got spinal cord lesions, and this patient was oligoclonal band positive and definite demyelination. This patient had their lesion removed, and the histological report was very vague. They had a temporal lobectomy, and it came back as an inflammatory lesion. They're still well now. I remain a little bit unsure of what this is going to be, as to whether it's just an unusual tumour. Maybe it might be an inflammatory lesion, maybe a sarcoid, neurosarcoid lesion. I do feel uncomfortable about calling it inflammatory demyelination, and worry whether or not he's going to come back with a lymphoma. And this was a sentinel lesion. It's a little bit unusual. I'm going to mention treatment and finish off on a couple of slides on treatment. So treatment, is important to be aware. The first thing that the British Society of Haematologists said in their guideline about treatment is the patient fit for intensive chemotherapy. If not, whole brain radiotherapy, plus or minus oral temozolomide and rituximab. The reason being is the treatment is brutal. Patients have to be really fit for matrix chemotherapy. Although it does well for the patients who are fit to have it, there is actually a 6% treatment-related deaths. So when you understand that concept, that 6% of your patients may die because of the treatment you're giving, you can see now why the haematologists and the oncologists who treat primary CNS lymphoma are adamant that they want definite histological confirmation that there is disease, and they won't treat patients based on the radiology alone. Going back to those guidelines, they did give us some advice about what we should do as radiologists for following up treatment assessment, and we should do it 1 to 2 months after they completed their consolidation therapy, and then they should probably have imaging every 3 to 4 months for the following 2 years, and then further surveillance imaging judged on individual patient basis, because a lot of patients don't actually make it beyond this point. They don't make any comment in the guidelines here about follow-up imaging and whether that should be reviewed by a neuroradiologist. So to conclude, we have done a whirlwind tour of conventional and advanced imaging spectrum in CNS lymphoma. We've talked about steroids in CNS lymphoma, and why we need to train our neurosurgical registrars to avoid giving steroids in lymphoma. I've introduced the concept of sentinel lesions, which has actually been around since 1996, but I think it's something we still just put in the back of our minds and forget about, and understanding the limitations of histology. We've been through some of the mimics, and we've talked a little bit about treatment and response assessment. So if there are any questions, if you don't want to ask me here directly, feel free to email me. Thank you.
Brilliant. Thanks so much, Sam, for such a comprehensive overview and amazing imaging examples, which really showed us such a great overview of the different types. We've got quite a few questions, so I'm just going to go through them and group some of them together. So one of them is relating to hemorrhage and lymphoma, which we have also seen. And we've got a question which basically said that neurosurgeons are reluctant to biopsy lymphomas as they're quite vascular and can lead to catastrophic intraparenchymal and intraventricular hemorrhage in the deep locations. And there have been some recent papers commenting on the use of amide proton transfer, MRI, and differentiating lymphomas. Do you have any experience with that, or can you comment on that?
So I don't have any personal experience of that. I understand where the haematologists are coming from, because they're reluctant to treat these patients because the treatment is so brutal that a lot of patients die on the treatment. They do sometimes bleed. I think as it is at the moment, we still need to work on researching this and developing better both imaging and other diagnostic tests. It's interesting how CNS, if you LP patients, only a very small proportion of them will have cells that are of any use. Circulating biomarkers might be a way of the future if we can get those that are diagnostic. But I understand where the surgeons are coming from. I think some of the newer techniques, it's going to take a lot to persuade the haematologist, though, to adopt them in clinical practice. And I think we're a way off that yet. But you're right, there is this whole cohort of patients, if they don't get a diagnosis, they're cast aside and they're left under follow-up of palliation or neurology, and they're not managed appropriately as primary CNS lymphoma should be. And it's we're doing a disservice to those patients at the moment. So we do need to improve our diagnostic techniques. So research in this is called for, but I think we're a way off yet before we can have alternative ways of diagnosing it.
I mean, a couple of us are saying that we have anecdotally seen that, you know, hemorrhage in lymphoma is, you know, we've seen this. Is that something that it's been in your experience as well?
I haven't seen it very often. I've seen it sometimes in the immunosuppressed and sometimes in the patients that have received steroids. And again, I think it's probably one of these treatment confounders. If you can get the neurosurgeons to stop steroids at the outset, that is a big advantage. And that's probably the easiest step in the first way is, if you think it's lymphoma, tell them that you think it's lymphoma and withhold steroids. And I wonder whether we should really put that on our radiology reports. Please don't give steroids.
I mean, sort of following on from that, I mean, you've talked about quite extensively and talked about not giving steroids before imaging, but I mean, if your patient comes to you and they've had quite extensive steroids before imaging, can you comment on sort of, you know, tips for making the diagnosis on the post-steroid imaging?
Well, I would take the age of the patient into context. Most patients are older. It's unusual. We had that one patient that was 37 with her sentinel lesion. I would look at all the imaging sequences together, look at the pattern. Is it at the brain CSF interface? Okay, so if it is callosal or if it's on the brain surface, if it's deep within the brain and there's no touching the CSF, is less likely to be lymphoma. The enhancement pattern, of course, is confounded if they've had a lot of steroids. Hemorrhage can be confounded if they've had a lot of steroids. If it's very cellular in some bits, as long as there's not a lot of hemorrhage, because of course that can confound as well. I think more along the lines of lymphoma rather than a GBM. But of course, these are all just vague rules, and you know that you're not going to be right all the time. But those are the things that I would use. If it's at the brain CSF interface, so it's periventricular, it's sitting on the cerebellum surface or on the cortical surface, and it looks like it's a lymphoma with that restricted diffusion and more homogeneous enhancement pattern, I'd be screaming lymphoma.
Have you noticed that, you know, pre and post steroid, or, you know, a certain length of steroids has altered the diffusion characteristics significantly?
So you really want to image them quickly. I mean, that's the other reason it's probably, if they are on steroids, if they've only had steroids for 24 or 48 hours, you can probably get away with imaging them. But if they've had steroids for a week, you're much more likely to get the steroid effects. So imaging in a timely fashion is very important as well. The same way with stroke. It's no good imaging your acute stroke a week or 2 weeks down the line, because your diffusion weighted imaging is going to be altered due to the timing issues. You've got to do your imaging in a timely fashion. And steroids, they reckon the maximum effect is reached at 48 hours, and then it sort of plateaus.
Brilliant. Well, we'll maybe just have one last question before wrapping up. So just one question which says, how often is radiological diagnosis relied upon for empirical treatment in your experience at your centre?
At our centre, never. The haematologist will not treat based on radiological diagnosis alone. The oncologists will then sometimes take the patient and palliate them, but the palliative treatment is the same for primary CNS lymphoma as it is for GBM. So, you know, they've not got a diagnosis, but they get that suboptimal treatment. If they've not got a tissue sample, they don't get treated.
Yeah, that's pretty much the same in our experience too. Okay, so thank you so much, Sam, once again. Brilliant talk and amazing examples. This talk is recorded for those of you who have maybe only managed to tune in